Here, a case of phacoemulsification in intumescent dense cataract, shallow anterior chamber, and narrow pupil. As you can see, this is the maximum dilated pupil. I started the surgery using 2.4 keratome, clear corneal incision, then injecting intracameral midrain. But unfortunately, the pupil doesn't respond and doesn't dilate. Then using the Trepan blue to stain this white cataract under the air bubble and injecting dispersive OVD to prepare the pupil to insert the Malusigine pupil expander ring. As you can see, this is the ring and this is the injector. You can put the first eyelid in the pupil border, then these two eyelids. Here is very important to be little bit vertical to be sure that both eyelids are pushing the pupil border. As you can see here, the last eyelid hanged with the injector, then using the sensitive to release this eyelid, then using the biforked instrument to push the last eyelid to be within the pupil border. Now, as you can see, you have a very good pupil diameter, which is about 6 millimeter. So we should thank Dr. Boris Malusigine for this Malusigine ring. Then, as this intumescent cataract, I prefer to use the double rhexis technique to avoid the peripheral extension and the high incidence of Argentinian flag sign in this type of cataract. Then using the bimanual irrigation aspiration to aspirate the liquefied cortex, to depressurize the intralenticular pressure to prevent the incidence of peripheral extension while doing the second large rhexis, then injecting again dispersive, then doing small snip using a micro Caesar to enlarge and doing the second large rhexis. As you can see now, it's easy to do the second one after depressurizing the intralenticular pressure. Now you have a very good, beautiful capsular rhexis. As you can see, by using this beautiful pupil expander ring, we obtain a very good dilated pupil and a beautiful capsular rhexis. Then just be sure that your nucleus is rotated very good. Then just injecting dispersive OVD. Now the time of phacoemulsification with this hard and dense cataract. I'm trying to do the vertical chop technique, impale the phaco-tip in this hard nucleus and put the chopper vertical and try to separate side away. As you can see, trying to chopping this dense nucleus into smaller pieces. Then you can hold each piece and emulsify this piece at the level of the pupil, then continue chopping and emulsifying this hard nucleus. As you can see in this dense cataract, it is also important while emulsifying this hard cataract to re-inject a dispersive OVD, as you can see now, to protect the endothelium of the cornea, as you need to apply more power during emulsifying this dense cataract. As you can see, chopping off this hard nucleus and emulsify each small pieces at the supranuclear space and the level of the pupil, which is a safe area as it is far from the endothelium of the cornea and from the posterior capsule. Now you can see there is just little cortex using the bimanual irrigation aspiration to remove this cortex and to do gentle polishing to the posterior capsule. Now the posterior capsule is good and clean. Using the cohesive OVD to fill the capsular bag to inject a hydrophobic single piece IOL. This is the lens now inside the bag. And now, before removing the OVD, it's the time to remove the pupil expander Malugen ring using the Sensky to free the first eyelet and using the biforked instrument to release the last eyelet, and then using the injector to pull this ring out the eye. As you can see now, the surgery went without any complication. Now removing the OVD, the pupil is good and rounded and it is not distorted. And thank you again for Dr. Malugen for this ring. Thank you for watching.